The broadcast is now starting. All attendees are in listen-only mode.
Well, good morning and good afternoon, everyone. I know we have employers and consultants joining us from across the globe, so I want to welcome everyone, first of all. Thank you for joining. My name is Andrew Stalker, and I'm head of MetLife's employee benefits business for the Gulf. Let me be the first to welcome you to MetLife Gulf's Thought Leadership webinar series entitled The Future of Telehealth, Moving Beyond the Walls of the Clinic. MetLife's webinar series, such as this one today, focus on delivering informative and topical thought leadership that impacts a broad population of the region and the world. Before we get started, I want to take a moment to update you on how MetLife is working to keep our customers and team members safe and connecting with the communities we serve. Here at MetLife, we are working diligently and around the clock to continue to navigate the public emergency while continuing to do our work. At MetLife, we've made significant adjustments to our practices and the support of our partners and customers in hopes of minimizing the short-term and long-term physical, mental, and economic impact that COVID-19 is having on our society. We've deployed digital resources to our partners and customers and members to ensure you can connect with us and benefits from anywhere around the world. In addition to our existing telehealth services, we've aligned quickly with our healthcare providers to ensure that our members can seek care from the safety of their home. We took unprecedented steps to make mental health services available to all of our customers and extended those services to our broker and consulting partners. We've launched a series of online seminars to help our customers and their members navigate new health-related concerns. And we're now currently working with our partners and customers to address the rising economic concerns resulting from the recent lockdown and crisis. These times are challenging, nothing like we've ever seen before. Yet the humanity that binds our world, the UAE, and our company is stronger than ever before. And we look forward to continuing our mission to take care of you and your loved ones today and into the future. One quick housekeeping item before we begin today. On your screen, you'll have the ability to expand the Ask a Question bar. Once you do that, type in your question and simply press Enter. If your question is directed at one of the panelists, please be sure to clarify that in your question so we can direct it to the right individual. We will address the questions during the Q&A, which is towards the end of the webinar, but please go ahead and ask them at any time. So it's my pleasure to provide a brief panelist introduction, and I've asked each of the panelists to share a bit about themselves and their organizations when we get to the panel discussion in a few minutes. Heba Al-Hassan is a pharmacist by background with 15 years of diverse experience across the Gulf. She's the head of medical networks at MetLife, managing the entire healthcare network relationships across the Gulf. Raouf Khalil, joining us from London, is the founder and CEO of TrueDoc 24/7, founded here in the UAE in 2011, and leverages a diverse and global 33-year career in outpatient healthcare services. Raouf, thanks for joining from London on your travels. And Hein Van Eck is the Chief Strategy Officer at MediClinic, has been with MediClinic in Africa and the Middle East since 2005 and moved to Dubai in 2014. Over the past 3 months, I've had the opportunity to partner and participate in several digital customer roadshows, a listening tour of sorts. Noir, if you wouldn't mind just moving to the next slide. As we near the conclusion of these events, it's clear that three general topics weigh heavily on the minds of HR leaders when it comes to how to evolve the current employee benefits plans to support new demands of their workforce. Those have been generally included home wellness and prevention support, mental health availability and support, and telehealth. Under the topic of telehealth, employers listed their concerns as the three following. Generally, what options are available for my employees, how to encourage employees to use telehealth solutions that are available, and if or how telehealth can support the rising cost of healthcare. A few things are sure when it comes to telehealth. It's here to stay and will likely evolve faster than any other component of the healthcare delivery system. As a result, we thought it would make sense to host a panel discussion with these experts and hear your questions. Okay, next slide. Some might find it interesting to learn that telehealth has been around for nearly half a decade. And in recent years in the UAE, telehealth has been identified as a pillar to support the transformation of the medical system in the UAE and the broader Gulf region. Just prior to the pandemic, in fact, the health authorities across the UAE had already issued telehealth standards, which acted as, if you will, a formal stamp of approval on the telehealth industry. With the recent and rapid acceleration of telehealth, especially in light of COVID-19, there's much consideration being given to the opportunities and the risks associated with telehealth. Noir, if you just move to the next slide, thank you. The good news is that most cases, the opportunities are outweighing the risks. For opportunities, those include things like the efficiencies of things like travel and time cost, as well as waiting room time, many of us are familiar with, consumer cost in general, great access to quick preventive checkups with providers, and great access to specialists. There's a few risks, but they are certainly worth mentioning and exploring. Those being potentially misdiagnosis or diagnostic errors, patient confidentiality on various platforms, and then the patient journey, scheduling, co-pays, filling claims out. I, for one, have used telehealth now 5 times for 3 individuals in my household. I found certainly the benefits to outweigh the negatives, but at times I still find myself somewhat bothered by the various ways in which we communicate and connect with physicians through different telehealth platforms. I'm hopeful that that obviously will evolve in time as we move forward. So as you can see, fair to say, helping consumers like myself or you all to have a great understanding of the benefits and concerns associated with telehealth is important. And so without further ado, let's get into the questions. And again, I'd encourage you to ask your questions as we move along. So my first question is for Heba. I'll start with you. As I presented during the slides, telehealth has been given a stamp of approval by local regulators and the health authority in the UAE. Just recently, there was an announcement early March that asked for all providers to stand up telehealth services. So what's that meant for insurance companies, and how can members now seek care through their insurance plans through telehealth services?
Hi, first of all, good morning and good afternoon, everyone. I am Heba Al-Hassan, the head of medical network at MetLife. As you stated, Andrew, it was the formal stamp and approval from the DHA and the regulators to get the telehealth started. So basically, the patient and the community safety are the top priority for the health regulators. The payers and the TPAs were encouraged to accept claims from in-network licensed providers The directive, though, did not mandate the default inclusions of all and each provider. But here at MetLife, with the support and with the help of the providers, we were able to support the community because we were equally concerned, like the regulators, to provide and create the telehealth network to a great number of direct pay providers for the member choice and ease. In a simple word, it means access to the patient. So a great number of providers with great specialties. I would like to take a step backward and say, or briefly define the telehealth. So what is it exactly? It's the distribution of health-related services and information via electronic technologies that allows long-distance care between the patient and the clinician, monitoring, advising, wellness, and intervention if needed. So basically, the online consultation, the intervention that the doctor can give you is just a simple example of what can be given through telehealth. This could be extended to telelab and teleradiology as well, and we successfully concluded this with even adding on the medicine delivery to make sure that you get your prescription from home. So basically, this is in a nutshell. If I may summarize and tell you, like, what does this mean to a patient and to the healthcare system in general? It's access, safety.
Great, thank you. Thanks, Heba. I'll come back to you in a moment. I want to ask, since we're talking about the providers having recently established telehealth services, or certainly focusing on this, I'll turn to Hein. MediClinic is a leading healthcare provider in the region, and certainly I think everybody knows it by name and quality of service. There was a recent media communication from your CEO, David Hadley, and he had said, if I'm not quoting him correctly, that virtual health is here to stay, and MediClinic is investing in this area of the business. Would you mind sharing with us a perspective on the future ahead for MediClinic and telehealth?
Just had to unmute myself there. Andrew, thank you very much, first of all, to you and Heba for having me on this webcast. It's certainly a privilege for me to be here. We've always had a fantastic relationship with MetLife, certainly a company that shares our values and our professional approach. So thank you very much for that. Andrew, if you don't mind, I'm just going to say 1 minute for those who are in different areas, just a quick background on MediClinic. MediClinic is a company that started in South Africa. I'm also South African. We London listed. We've got 3 platforms, Switzerland being our financially the biggest platform with 17 hospitals, just over 2,000 hospital beds. It's the biggest private hospital group in Switzerland under the Hirslanden brand. We've got MediClinic Southern Africa with 52 hospitals. That's the old mothership, certainly operationally by far the biggest. And then, of course, MediClinic Middle East with 7 hospitals and 20 clinics being the growth platform, so to speak. And we also have a 29% shareholding in the Spire Group in London. So overall, sort of just under 12,000 beds, £3 billion worth of turnover or revenue, just to give you a sense of where we operate. So in terms of MediClinic's view of the future, virtual health is certainly here to stay for us. MediClinic International has taken the view that we wish to become an integrated healthcare provider across the continuum of care. We take that very seriously. In other words, we look at all our platforms and we identify areas where we don't have all the healthcare services. In other words, MediClinic in certain areas are very much hospital focused. In the Middle East, we far more healthcare system, what you would call, but we do have gaps within that system. On the wellness side, the preventative side, if you look at long-term care and other areas, there are gaps. but more importantly is the digital transformation that comes with that. And that's where the virtual health comes in for us. And that's really to look at how you get paid, and therefore, how do you connect all these different areas? Because if you get paid fee for service for things, it's very hard to connect them. So that's step number one, that's part of that journey. And then, of course, virtual health for us, we see as something that's now been fast-tracked. It's always been part of our strategy. We just fast-tracked everything, and we wish to not see it as separate service lines. We do see it as something that needs to run integrated with our physical care that we provide. It's not about pushing the one over the other. It's about what makes the most sense, what is the most convenient for the patient in terms of whether telemedicine, remote patient monitoring, remote ICUs or tele-ICUs, all these kind of areas is getting a lot of focus from us at this point in time. Of course, when COVID hit, we had to really get out of the blocks really quickly in terms of the telemedicine solution. The one thing I would say is that it really focused, or it aligned the incentives for everybody. I think in the past, telemedicine to a large extent, there was always this friction for doctors, you know, saying, why should I go do telemedicine if I'm not getting paid the same as what I would get paid if I see a patient in my facility? So there was always that pushback, the way funders would see it, you know, payers would prefer to provide that service themselves. But certainly this, what has happened now, has really got us out of the blocks quickly. And I'll share a couple of interesting things that we've learned a little bit later. But this is certainly a journey for us. We're busy with the appointment of a head of virtual health. So this area will receive a lot of attention from us.
Great, thank you. Very, very intriguing background on where you guys are. I do want to come back to the point about convenience for the patient and sort of how you view the customer journey. But I want to ask Ralph a question and go with that same question for Ralph. You know, TrueDoc has been a veteran in the telehealth services in the UAE and broader region. I know you're not just in the UAE. I think several different markets, including Egypt. Why don't you give us a quick update on the journey that TrueDoc's been on, as well as where your focus has been the last few months related to or unrelated to COVID-19?
Hello, everyone. Thanks, Andrew, for having me. TrueDoc was founded actually in Dubai in 2011. The model, though, was based on a company I founded in 1989 in California. And the sole mission since then really has been to align patients and payers to find a real solution to healthcare. So at TrueDoc, currently we have about 4.1 million paid subscribers in multiple countries, with over 6,000 corporate clients and multiple government contracts with 0 malpractice claims. We have full-time doctors and therapists, nurses, wellness advisors, as well as case managers in our 24/7 call center. Our doctors are full-time employees who are paid a flat salary with no financial incentives to overutilize. So when patients call us, we simply tell them the truth about what they need, not what they can afford. We also have a full-time IT department to support our one-of-a-kind continuum of care delivery system. When we started actually in 2011, we quickly realized that telemedicine alone does not work, particularly for the costly chronic patients who actually consume 82% of medical costs. So since then, we have added an integrated mobile app, on-site virtual clinics at employers' offices and accommodations. We also started employer-based clinics and the hospital-at-home program, which includes 24/7 telemonitoring, as well as the monthly outcome reports we issue for our clients. There's one point I would like to make here. It's very important about telemedicine as an entry point to a clinical event. It's either could be used as a revenue model or a savings model. The key value for telemedicine is not just the technology platform, but it's actually the doctor that you actually first interact when you have a clinical event. So you have two possibilities. One is you connect to a doctor who's financially incentivized to overutilize for commissions. And the other option is a doctor who is getting full salary with no financial incentives and simply follows evidence-based medicine. The potential from incentivized doctor, the potential damage is not just financial, but also clinical, as patients could be getting unnecessary and potentially harmful procedures and medications. Now, as far as the COVID, what we've done for the COVID-19, we've helped educate our members with everything that has to do with COVID for the last several months. We ensured that their safety by delivering medications to patients' home. Even lab draws are being done at home now. More importantly, we were able to keep our hospital at home program chronic patients safe at home from having to go to clinics or hospital with the potential exposure to COVID-19. We have also recently added a COVID-19 symptom checker to our mobile application. So this is really a nutshell about what we've done for the last several years in Dubai. We've expanded in multiple countries as well.
Ralph, thank you very much, and I appreciate obviously the depth of perspective that you have providing telehealth services as well as additional services to customers in the region over the course of the last near decade. I want to switch gears and talk a bit about patient journey, and I'd like to turn to Hein. Hein, you talked about convenience for the patient. When you think about that journey ahead as you're building out the capabilities, you talked about the integrated model. Can you share yet a perspective on what type of technology you'll be using, how patients will interface, how they might pay copays, the technical side of what HR leaders would want to know about how to help their employees navigate what might be a big part of certainly acute, maybe chronic disease. We're going to talk about that delivery into the future. Hein, if you're muted, then unmute.
Sorry, I was trying to unmute it. Okay, Andrew, I think first up, I want to just quickly touch on a point that Raouf made very eloquently, and that's the incentive part. I think in this region, it's important for me to just note that Mediclinic is certainly never paid any kickbacks or commissions on lab tests, pharmacy prescriptions, radiology tests, and such like. So I think it is very important. We definitely support the stance that TrueDoc is taking there, because ultimately you want to get paid for what is necessary, not try and overutilize, and therefore in the end the payer and thereby indirectly the employee or the individual pays for it. So in terms of how we see the journey going forward, of course, at the moment where we stand with our telehealth, we were fortunate in the sense that because we had to get going with it so quickly, we couldn't integrate everything in one go or immediately. And therefore, we utilized our contact center. We've got a very large contact center, with numbers for Dubai and Abu Dhabi, and therefore we could push the whole process through the contact center effectively. We're obviously working now to get all of those integrations done, and therefore that'll become more mobile, application-based, etc., etc. In terms of how we see the technologies for the future, we are certainly not scared to take risk. In other words, once again, I talk about the funding first, because when you talk about the funding, it shows, how the whole strategy can move in that direction. So we are quite comfortable going into capitation kind of models, population health kind of contracting with payers. And with that, of course, comes the necessity in order to utilize population health principles. And this is where telehealth and remote patient monitoring and all these important tools become very important. They're not shiny objects for us. The technology is just the enabler in order to make it a smooth and an easy process for the patient. But we would like to go into those kind of partnership models where it's not a question of us sitting over the table saying, for this telehealth, what is the fee for telehealth? What is the fee for when the patient comes in? So we are talking to, I'm not at liberty to say who the vendor is, but some very strong technology providers on the remote patient monitoring side. Some very exciting stuff in order to remotely monitor chronic patients, so that we can basically do virtual rounds on the patients, where we're able to also optimally utilize the resources that look after that patient. So the patient gets the peace of mind that they see somebody is looking at their results. They can actually see that somebody has read their results. And on our side, we have a dashboard that shows us which of the patients are out of range, and therefore who needs to be followed up by a nurse call, or perhaps a doctor video consultation, or of course, following on from that, the patient will be triaged into the physical facilities if required. So really, we do see this greater focus on population health, and therefore all those technologies, that run with that. The other thing I can mention is some very interesting technologies we're looking at in order to basically build your protocols and your pathways into your applications. So in other words, wherever the patient has that access for a video consultation, if there's a treatment plan that gets agreed, that treatment plan is in the application. And therefore, the patient gets reminded what to do when. The patient gets told after an operation, this is day 2 after your operation, where's your pain score, this is how you should be feeling. If your pain score is higher, do you wish to talk to a doctor at that point in time? So it's really that kind of journey stuff that reminds you how to take care of yourself after the fact, when to take your drugs, because we find that compliance in terms of taking your medication and doing the right things post surgeries is often half of the problem.
I think I'll look for a confirmation to this, but from what I heard, and I'm going to go back to his point about 83% or so of claims are related to chronic conditions. Would you then say, when we think about telehealth as it relates to MediClinic, certainly in your strategy, this is not just about management of acute calls, skin conditions, rashes, bumps and bruises, and coughs and colds, but in addition to that, a platform that allows you to manage, again, as you mentioned, population health management or whole health, entire health. I just want to confirm that, because I think that's what I heard, and I think that's probably what HR leaders are thinking about when they're thinking about what telehealth can offer.
Yes, Andrew, that's 100% correct. So how we see it is in the fee-for-service model, healthcare providers are trying to optimize their capacity, right? You're trying to run your hospital at a 70% capacity or 70 to 80%. When you take a population health view, of course, then you can say you can still be at a optimal capacity of 70 or 80%, but you're looking after a much bigger population because you're proactively managing that population so that they don't have to come to the hospital so often. So your beds are still full, but in essence, you're looking after a bigger population, and therefore for you as the payer, your premium can be reduced, because that utilization of hospital services comes down. So you're 100% correct. We certainly don't want people to come in because they've got a disease that can be managed properly and in a safe manner without them needing to fall off the wagon, so to speak, and come into hospital.
Great, thank you. Thank you so much. Raouf, I'm going to turn back to you on chronic diseases. And in fact, we're quite proud that we've launched a disease management campaign in partnership with TrueDoc, and we've already seen what I would define as important results, those being positive, exciting important results to the positive for those who are in the care of your program. Talk a bit about your view on telehealth for this element of chronic disease.
Thanks, Andrew. Actually, there is some facts that that's related to these patients, which I've been working with since 1989 in the U.S. We know for a fact that, again, 20% of the population consume 82% of medical costs. Chronic patients will never believe that telemedicine alone can manage their conditions. Thirdly, a majority of the high-risk chronic patients don't just have one chronic disease, they have multiple chronic diseases. So having a disease management program, a single disease management program, typically doesn't work and it's not very effective. Chronic patients actually go to clinics and hospitals to see doctors, not nurses. So we must give them what they want. Having a home health nurse going and doing 12-hour shifts at home with the patient, and then once anything happens, any condition arises with the patient, especially after 5 o'clock, the nurse would call the ambulance and the patient will end up going to the hospital for potentially an avoidable hospitalization. We started our one-of-a-kind hospital home program with DHA in July 2017. Both patient satisfaction and savings have exceeded our expectations. All the financial analysis and actuarial work actually was done by a third party, Lux Actuaries, and has been confirmed by DHA. At our hospital home program includes an initial full examination at the patient's home by our doctors to establish their medical record, upon which that medical record at that point is installed in our call center. Our doctor teaches our patients how to use the telemonitoring devices, and they actually set a specific range for their vitals for each patient. The patients are actually monitored 24/7 from our call centers by our doctors, and if there's any out of range for any particular patient, our doctor would actually call the patient within 2 minutes. And if we can't help the patient over the phone, we actually send them a doctor at home, even at 3 o'clock in the morning, to avoid the unnecessary hospitalization. The in-house, the goal of the hospital home program has been to reduce the average length of stay at the hospital and avoid unnecessary readmissions to the hospital. Our the in-house IT telemonitoring devices that we work with, allows us to spend money only when there is an imminent clinical or financial risk. In other words, we're not going to be sending a doctor just to do a visit. The patient has to be out of their vital. There has to be a reason for us to spend the money and send the doctor to the patient's home. So you can call that we actually do stratifications on a daily basis to manage the regression to the mean and avoid wasting money. So this program has been really started in the 90s with my home health and home infusion company. And we collaborated with Johns Hopkins University for several years to enhance this. And here in UE and other countries we operate in, we've added the technology piece. So that way, again, we don't spend any money unless there is an imminent clinical financial risk. So it has been very successful, and it really helps keeping these chronic patients stay at home away from, again, hospitals and clinics to avoid the potential of COVID-19.
Thanks, Ralph. I think what's great about both what you've been working on and certainly what Hein commented on is going to be built gives us a view that telehealth is not just about, again, the call you make to a provider for a refill of a medicine or a common cold or flu, etc. It's going to be more about entire patient health, entire patient journey, integrated. So I think the future ahead is bright for this type of model that will improve the customer journey, but also give providers such as MediClinic and others an opportunity to leverage technology to likely manage their own costs, which I'm sure this day and age are challenging for that business themselves. Heba, I'm going to wrap up with you. We've got a couple questions that have come in from the audience, so I want to get to those. But I do want to go back to this discussion earlier about cost. MetLife is put in the position as the responsible party, if you will, to manage a claims fund as best it can for its customers, the shepherd of the claims fund, if you will. So it's always on our mind, and that discussion in the webinar conversation, it dawned on me that it would be good for you to share a bit about what you do with providers. How do you manage cost? How are you thinking about the future as it relates to how telehealth integrates into that cost, those cost discussions that you have with your providers all the time?
Thank you, Andrew. So basically, the optimum goal is to save costs in that perspective, and the way we negotiate this, and again with the help of the providers, were primarily to significantly reduce the cost of the consultation. But I could say it is too early to justify or estimate how much would be the future savings. That we just got started like 3 months ago, and we are yet to see the results and estimate the percentage or the impact, because as a matter of fact, the telehealth medicine in the UAE in particular is still in its infancy stage in this region in particular. But what we do and what we make sure to achieve and attain with the provider is deeply negotiated rates to ensure that this reflects on the policy and reflects on the patient sharing copay. It depends, of course, on the policy terms and conditions, but the cost won't be necessarily on the claims fund as well, Andrew, in my view. And as you, Raouf and Hein stated a while ago, it has definitely an impact on the time travel, the transition of the doctor from one patient to the other. Probably the doctor would see more patients when you get to the online or to the telehealth virtual care consultations, so on and so forth. So I don't have a specific figure on the cost saving as we speak right now, but something that I can assure everybody is the providers and us are working very hard on having a cost saving model, and it really depends on the model chosen, whether it's a capitation or transactional. But as we speak right now, it is transactional, and the consultation rates from a virtual care perspective is heavily and deeply negotiated, significantly when compared to the classic and traditional in-person consultation.
Andrew, I'd like to add a point, if I may. We really live in a different world now with the COVID, and the economic environment in the next 5 years is going to be impacted greatly. So there's no way employers can sustain the premium increase every year. And I believe there has to be a new healthcare delivery system, and we believe our population health management does exactly that, because it saves lives and it also saves livelihoods.
Great, thank you. All right, guys, so we have about 15 minutes left, and we have 6 questions, so we've got some work to do here. I'm going to ask probably one of the more controversial questions, and I look forward to the feedback from Hein and Raouf. These are questions coming from our customers. This one was directed at me, but I really think that the 2 on the call could answer, and then I'll give my perspective as well. Having just read an article about the technology firms' play. Do you feel that telehealth applications and technology will potentially eliminate the need for outpatient clinics in the future? So let me start with Hein on that one. Considering you are a brick and mortar, moving to telehealth, but brick and mortar, what's your view on potentially how this world will evolve from an outpatient perspective, especially, I'm sure, from an acute perspective?
Yes, Andrew, I do think we've always said that we believe, our outpatient services will be heavily impacted by video consultations going forward. Of course, COVID has now just fast-tracked that. I think there will always be a place for a physical consultation. So, probably I'd say if I were to take a guess, in the next 5 years, probably 5 years from now, you could potentially see 50% of outpatient consultations being done via video consultations. And I subscribe that to people getting more comfortable with it. The 5G technology that's coming, so your video quality and your latency is just going to become better and better over time. There's some fantastic technologies out there in terms of point of care devices, where, all-in-one devices, where there's a little camera even in the device, where a mother can assist the doctor, pediatrician, to do a consultation on her child, whereby you put that camera in the ear, up the nose. You can measure, of course, the normal vitals, and I think that just takes teleconsultations to another level. So people will get more and more comfortable with it, and therefore it's important to find for the payer also to look at, if you look at the savings, if there are savings, there are two things that could happen here. If your teleconsultations are priced at a cheaper level, which is the case at the moment, then of course you need to look at your utilization. In other words, are people now accessing consultations that previously they wouldn't have? But at the same time, some of those consultations are now replacing physical consultations. So that's a real saving. But if there's an increase in the utilization, that is, of course, an additional cost, which once again brings me back to how important the funding side is. The transactional versus the subscription or capitation kind of models. So certainly, for me, without a doubt, we're going to see a big shift in not overnight, but in the next 5 years, there's going to be a big shift.
Ralph, you want to have a position on this?
Oh, yes. Well, you know, since 1989, and I always advocate that money should be spent on patients and doctors. You know, brick and mortars should be also only for emergencies and operations. I can assure you, I mean, we had a great hospitalist program. Our doctors were doing hospital rounds at Cedars-Sinai in Beverly Hills, which is the most expensive hospital in the world. And we were able to reduce the average length of stay and give the patients the option whether you want to stay in the hospital for another week or we can send you home today with IV antibiotics. And the patient's benefits and the payer benefits, the main stakeholders. And I would love to introduce the hospice program in the Gulf region, because I can assure you, if we send one of our hospice doctors to some of the hospitals, at least 65% of these patients will be discharged the same day, because we do everything at home since 1989. 5-FU chemo, IV antibiotics, IV pain management, especially with having the doctor available 24/7 with the call center and home visits. So I believe that healthcare is like any other industry. It's supply and demand. I believe there is too much supply in the market. And I believe the economy in the next 5 years will dictate what is the right balance between supply and demand in healthcare.
Fascinating. Somebody wanted my opinion, and I think mine is that, as Hein and Raouf have suggested, technology will, in a way, force its way into this industry, and the integration of the existing providers with technology is what is going to ultimately define the model. And I think, as we've heard from both of these colleagues, both of these panelists, certainly that means a certain percentage, whatever that ends up being, who knows, will end up being done through telemedicine type services. The questions keep coming in and in. We're going to get to a few more of these, but now we're up to about 15. Let me ask this for all three panelists, if you have a response to this. Regulator challenges. Health regulation constraints. Do they exist today? Are they significant that it could potentially hold back telemedicine's future in the UAE, or are we on the right track with the regulators? Do we feel that there's adequate space to allow this to evolve quite quickly? I'll start with anyone. Heba, from an insurer perspective, do you see any regulator constraints there, or constraints from a legal perspective?
Well, I was thinking about this question when the telehealth started, especially with the presence of different regulators in different emirates, and a lot of questions around the liability, the medical liability between different regulators. I think we do have challenges and constraints, and I think the consolidation probably around the regulation of telehealth might resolve for this. But on the other hand, I think the regulators also, when they set the basic guidelines and the primary guidelines, made it very easy for everyone to start the telehealth and the virtual care within each and every emirates and region. So yes, we do have constraints, and we might even find more on the go. But I think that the government is very, very keen on developing the digital platform and probably revamping the regulations to make sure that the telehealth and the virtual health is developed and established in the UAE.
Yeah, Andrew, actually, TrueDoc has been very fortunate, because we had the exclusive contract with DHA to develop their own call center and telemedicine um, call center. And we actually developed all the guidelines and so forth. In terms of the regulators, I think COVID had made a huge impact on the regulators, politically speaking, because they knew that they need to avoid having people necessarily go to the clinics or the hospitals. So I think that advanced our mission a great deal. But the point that I would like to make, it's important, and be cautious, is about the high-risk patients in terms of malpractice. And I don't believe telemedicine can operate without a home health side of it, that actually we can actually touch these patients and make sure that we examine them and not just be handing medications over the phone. So this is an important element, and that's why TrueDoc is licensed as telemedicine and a home health agency.
I would just I certainly agree with the other panelists. The UAE government, all the regulators have been always been very supportive of new technologies. I really enjoy the fact that they engage with the private sector. Raouf has just mentioned how the DHA has done that for them, over the past, and certainly in Abu Dhabi too. New regulations coming out, lots of engagement with the private sector. The one area I would say at the moment that can be a bit tricky is around Law 2. So the fact that no healthcare data may leave the country, which is of course important. The regulations the enacting regulations have not been published yet. So the law is there and it's in place. But so some of the SaaS providers, sort of service as a software providers, their cloud-based solutions are not always based in the UAE. So we do find that when we speak to some of these, we always have to have that discussion around where the data lives and whether they can, build it on a cloud in the UAE. So that's the only thing, but certainly that's not something that can't be overcome, by no means. Great,
thank you, guys. We asked one question and four more came in, so up to 16 questions. We're not going to get to all the questions, so I will share with you that we have the information. If you ask the question, we'll get you the answer and we'll respond to you. But I'm going to use the last few minutes for one question that there were 3 questions in a way that came up. And you guys will recall that in my opening, I mentioned the risks. One of those actually was the platform, so thank you, Hein, for your comments. The other was misdiagnosis, this I think is a fear some people have. 3 or 4 of the questions were around the quality of physicians that are staffed to perform the telehealth service. The other was just, should I be concerned that there's a likelihood of misdiagnosis? And so I'd like to start those questions with Hein, with you, and then move to Raouf. What assurances can we afford customers and members and patients that they're getting the same standard of care when it comes to diagnosis, and there's protocols in place to ensure that telehealth doesn't overreach into areas that it shouldn't?
That's an excellent question. When we started with the telehealth, a big area of focus for us was the privileging and credentialing for our doctors for telemedicine. They had to go through a little bit of training. But the most important thing is you can put all that credentialing and privileging and note all the risks. The most important thing to manage that risk is the quality of your doctor. The doctor must know, if you've got a good doctor will know that and apply judgment that you cannot diagnose a patient if you are not comfortable about what you're seeing and hearing over this video consultation. If you're not sure, if you're not certain, you have to refer that patient either for a physical consultation, or if you feel the risk is low enough, once again, it's based on the doctor's judgment, you check in on that patient in a couple of days later. So my humble opinion is there are not enough protocols and rules that you can build around this. You must have quality physicians in your organization, and those people must practice good, safe medicine.
Raouf, comments from you?
Yes, absolutely. It's really a fine balance, Andrew, because we wrote our own guidelines for telemedicine. Now, the importance is to make sure that the doctor doesn't feel the pressure whether to avoid utilization or overutilize. And that's why they need to be left alone to do their own judgment with their own practice. The balance that we have at TrueDoc is actually 70 to 85% of the patients that call us, we manage them telephonically, i.e. they don't need to go to a clinic or a hospital. We deliver the medication to the home. And on the other side, we're very proud that we've never had one malpractice claim. Actually, I've never had one since 1989. So it's a very valid point, and we need to be very careful because everybody now is doing telemedicine.
And Heba, I'm sure you would state that over the years, as we advance with more and more providers, quality checks and SLAs around the relationships you have with providers, I'm sure will evolve to include this type of these types of conditions or concerns.
That's right, Andrew. I mean, the process flow and the KPIs were one of the hot discussions that we had with providers when we impaneled or when we created the telehealth network, as a matter of fact. So this is going to evolve also as we explore and more providers, and it depends really on the digital platform that each and every provider has in their system.
Well, listen, it's been great. I want to thank each and every one of you guys for taking the time out. It's a very busy time for everybody. A very exciting world ahead we are living as soon as we can get through the current challenges that our communities face, supporting one another. We'll have another opportunity to have a call together and update everybody on where telehealth has evolved, maybe later in the year. I want to thank you guys again, and have a great rest of the day. And everybody who joined us, we will try and get all the missed questions out to you guys over the course of the next week. Thanks so much for attending.
Thank you.
Thank you. Thank you. Bye.
Bye-bye.